Hi,
Hey.
how's Bernie?
Oh, alive.
He looks like such a cute shaggy pup. I love the shaggy ones.
His owner, he is the progeny of a Bernedoodle and a toy poodle, but he looks like a Basset mix.
So,
Yes, Dr. Foster.
I'm seeing if my slide viewing thing is just doing like the circle and not actually like getting the slides, so I have to figure out if they can show the slides. Hold on 1 second. Can only. Thank you. Where did my other file go? Okay. Yes. Oh, got it. Okay. Mhm. And then so I figured we could talk about him or Cheese. I think I can't remember
Yeah,
Cheese's boy.
his boy.
And then uh that same week, Dr. Gordon had sent me a sample from like a Doberman, I think, that has really good bacteria and really good like mineralization. So I can compare the two because your case didn't have any like we did the gram stain, but it was negative, right?
Yeah, and I think his culture
His culture was negative, it
came
says.
back negative. He's, I don't know. I feel like he's not FIC based on like the other histopath reports I was reading, but I'm also,
I think
that
there's such
was,
a wide variety and it has them in characterized. I don't know.
mm,
I think like um how do I want to say this? I was just confused because when you texted and you're like his bacteria you said something like his gram stain looks like mint chocolate chip ice cream. I thought that meant he should have been positive. Like I was just like, what? And then I was
mm,
like, maybe Steph misunderstood what I was saying. And then I looked at the slide. I'm like, oh, it's just because it's green.
yeah,
It's like there really was no like definitive
no,
reason for that other than it looked green.
yeah.
But maybe we'll just, depending on time, ooh, actually that would be going, do a little highlight of how the other special stains that we don't traditionally do. So it's a little bit more, I don't know, education and not necessarily like completely case based. Because we had your Bernie with the Von Casa and the elastin, and we just did a Tufts case where there was a whole bunch of iron. So we can just kind of show that. But I don't know. I did send out the email saying it was going to be mostly bladder, so nobody might, it's very possible no one will show up.
Yeah, Bernie has been very hyper. I just switched him to Sevelamer off phosphine. His phosphate's been like in the mid 20s.
I mean, we have never published it, but when I start to see tubular based membrane mineralization and when it starts to go around Bowman's capsule,
Yeah, we had examiners.
not good. So, I mean, he's not the worst. Like I've seen where like the entire core has that and they die within weeks.
Ugh, I need this
Um,
dog to do well. I'm obsessed with him and
well,
his owner.
and the other thing is like also these are cases that didn't get dialysis. Like these are just,
Right.
like really bad ones. And I was like, oh, this is bad. And then usually but like, yeah, so there's hope, but yeah, it's not, it's always kind of a scary thing when I see that. I like get a pit in my stomach when I say that.
Yes.
Yeah. And then I don't know what to do with his lab work. On half of our labs, like on our ISTAT and our blood gas, the sodium's reading at 122, but on like the IDEX chemistry, it reads as 140. And I
Oh,
don't know what
okay.
to do with that either. Yeah.
Hmm. Sounds like you have a laboratory issue.
Yeah. Yeah.
Let's see.
Just use
Uh,
the values that were, sorry, I'm on my cell phone. I'm sending students.
I can't hear you, Hokip. Are you talking to me?
Oh, is it not working?
It's doing like a cut in, cut out kind
You
of
know,
thing.
can't hear me?
I can hear you, but it's like I can't hear I can't hear
Oh,
everything.
alright.
I think she was asking Steph to repeat the values that were
Oh,
wonky on chemistry. It was sodium, right?
Yeah, yeah. When let's see, when Bernie came in on Monday, his on the blood gas machine and the iStat, well, on the blood gas initially his sodium was too low to read, and then it came back at 122, and then the blood gas machine went down and is not functional. And then also his like it clotted a little bit weirdly in the heparin tube. Like it definitely wasn't clotted initially, and then after we ran it, it was solid, which is weird. So I had my tech draw a new sample, and on the new sample, the iStat blood gas was 122 on sodium, but on the chemistry, it was 140.
And that was on
And
an
his
IDEX chemistry analyzer, you said.
Yeah, and then between the 3 machines and the 2 samples, his potassium read 3.5, 4.2, and 6.5,
that's a difference.
which made it very difficult to decide how to make his dialysate.
Okay, so is it everybody's starting to join? I know some people will probably filter in later. And also I did send out an email that it's mostly urinary bladder based, so there's a very big possibility I lost some of our usual attendees. So which is fine. That's why I did send out the email because I wanted to make sure that people knew it wasn't going to be a whole bunch of kidneys and electron microscopy and stuff like that. So, but there should be still some people that are interested in all segments of the urinary system. I am learning to love the ureters, the bladder, and the urethra. It's been a long fought process, but I do actually very much enjoy it now. And so we have a case to discuss that was brought up by Dr. Skinner at Friendship. We'll compare it to, and I actually saw Dr. Gordon on here. Sometimes he can't attend based on scheduling in Colorado, but I just wanted to compare it to one of his cases that has some better staining qualities. And then depending on that and timing, I might just kind of pop in some atypical or unusual, uncommon stains that we request on histology for kidney, because we've had quite a few of, just kind of weird oddballs in the past couple weeks that have had some nice staining patterns for histochemical stains. So for the pathology trainees that are in here, this will be a good review for you for histology. And the otherwise, I think this will give you a perspective of how difficult it is from cystoscopic biopsy samples to make definitive diagnoses when it comes to the wide variety of lesions they see on the urinary bladder. Steph will be and JD will send me great photos of what they saw, like little bubbles coming out. It looks like a little like it looks disgusting in that urinary bladder, and then I get the sample and it's like I don't see much. So I think that's going to be a good review for everybody to see that there's quite a difference. And I do think that pathology is going to the point where, especially since we're getting more cystoscopic images, that we need to combine those two when we're making our diagnoses and not just go by what the histology says, because if they see gross lesions in the urinary bladder and we can't just come back and say normal, we really should be focusing on how much edema there is, telling them whether or not there's inflammatory cells, and if they're there, what type of inflammatory cells they are, but also quantifying them. But we really need to make sure that we're incorporating the fact that there might be a bubbly urinary bladder or, erosions or small like microhemorrhages, that can be very helpful for them to at least know what they're treating. Housekeeping, as I always say, if you have realized you have not been invited to a session in a month, reach out to me. I will make sure you are on the distribution list. It does randomly knock people off. And I think for this past like 3 years, I've been really good at always at least asking for cases once a month. So there's never going to be a point where I forget to ask you. You might just gotten knocked off the list. And then if you have a case that you want to present and maybe we're working through it on the biopsy, just flag it and say, hey, that would be really cool, or could we discuss this later next month? And then that will actually alleviate one extra step of me begging for you guys to present cases. You know, we like to have the breadth of people presenting in this conference. And we can do anything from all the stages of the urinary system. And they are still being archived for later review because we have a lot of international people that now apparently watch this the next morning. Okay. Staff, would you like to begin discussing cheese?
Yeah.
I know that's
So
a great way to start any conversation. Let's discuss cheese.
Cheese, Cheese, who is brother to Mac and Gouda. They do have a naming convention at home, but so he's a 7.5-year-old-ish male neutered domestic short hair, and he came to see me in June of this year as a referral from our surgery consult. He was adopted a couple years ago, I think like 2022 or 2023, around that. And per the owner, the shelter had said he'd had some trouble urinating, and they got him a buddy, and he no longer had any issues urinating. He was happy. They picked him up initially for that first year, no problems at all. And then over the following year or two, he developed progressive hematuria, periuria, which culminated in a urethral obstruction in like October-ish of 2024.
And for clarification for those of us who are pathologists, periuria means urinating outside the litter box?
Yes.
Okay.
Yeah.
Thank you.
And all the places we don't want a male cat peeing. I think so at the time, there had not been an obvious mechanical obstruction, and he was diagnosed with presumptive FIC and got put on like gabapentin and a bunch of other stuff of questionable utility, like D-mannose and corn silk alcohol free supplement. I don't know, he's on a bunch of supplements, whatever. In like a couple of months later, he had another like semi-obstructive episode and then peed out a bunch of like mucousy crystalline material. The owner said he felt really good afterwards, and then his symptoms were back within like a week or two. And that's when he saw our surgery service to discuss a PU. We've definitely had, I think we've been seeing
And then for
more
pathologists, just to remind everybody, PU is a
yes, sorry. Right. Peritoneal urethrostomy.
Yes, peritoneal urethrostomy.
To essentially cut off the tip of his penis so that if there was obstruction, that he wouldn't be able to obstruct, although it wouldn't address the underlying inflammation. That might be the cause of that. But I think we've been seeing male cats that had been diagnosed with FIC, but in actuality, I think a lot of them do have like this matrix of like mucus and like teeny tiny little sandy stone debris, like more than just a crystal. Like when I think of a crystal, I think of something that is soluble and seen on a microscope as opposed to like an actual stone. And we've taken some of these to get PCCLs and like fleshed out the bladders and seen very tiny stones. Percutaneous cystolithotomy, sorry.
No. I'm just like, I always have to look that one up because I'm usually spelling it out. So for the clinicians or pathologists that probably never even saw one when they're in vet school, what's the process of that?
It's a lot like a cystotomy, except we're using a cystoscope to go into their bladders. It's a very tiny incision in the abdomen, very tiny incision into the bladder. We place a trocar, and then we flush the heck out of their bladder and get rid of all the tiny stones. We can also use like stone baskets to grab very tiny stones as well, or not so tiny stones. And we also are able to evaluate the urethra. We've certainly had patients where we've gone into their urethra and seen very, very tiny bits of like essentially sand stuck there that we were able to remove. And a lot of them feel a lot better afterwards. So in his case, he came, I did just a point of care ultrasound on his bladder, and I saw what very much looked like it was twinkle artifacts. So like on ultrasound, if you put on Doppler flow, you see the like red, green, bunch of different colors, which I usually associate with a mineral object. And I was like, great, he's got a stone, we can remove this, we can save his penis, he'll feel so much better. But when we actually went in with the camera, we did not see any obvious stones. The inner surface of his bladder didn't look horrendous. It was definitely a little bloody because I cut through some vessels on the serosal surface of the bladder. and it was like inflamed, but not terrible. And we did not see any obvious like debris or sediment. His bladder wall felt very thick. And at that point I was like, well, was like that mineralization I was seeing in the bladder wall itself. So we ended up taking, we just like sharply dissected some pieces of the bladder wall right around where we'd gone in with the cystotomy incision and sent that to Rachel.
Okay, and so again, I graduated vet school 20 years ago. It's my 20th anniversary. They're having their 20th reunion. And so just a review from everybody that what FIC is a subset of what FLUTD was, the fluted cats, or how do those two overlap? Are we not using one term versus the other term?
I will use fluted as a bit of a catch-all. For me,
Okay.
that includes cats that definitely have stones because it's
Okay.
like it's
Okay.
feline lower urinary tract disease. So I feel like people don't use fluted that much unless they mean FIC. I'll use
Okay.
fluted like prior to a more definitive diagnosis, and FIC is
Really
like
helpful.
my diagnosis once I've ruled out everything
When
else.
you've excluded everything else,
Yeah.
the interstitial cystitis is kind of the last diagnosis
Yeah.
that's left, even if you might not actually see inflammation or might not have the biopsy to prove that there's inflammation there.
Right. Right.
Okay.
Because we rarely actually
Actually
biopsy
biopsy them.
those
Okay.
cases.
And so whereas in general, like a term that I remember being beat into my head when I was in vet school is probably kind of passé now, but it is kind of a general, it's almost like when we say PLN, should we be saying PLN
Yeah.
anymore?
Right. Right.
Um,
Exactly.
okay. Um, that also because I was always figuring out like which one fits it to everything when I'm trying to write the histories, and I think that's what's been very helpful for me too is to try to synthesize all this into the history so I can use the same terminology you guys use. Do you have any images that you want to show from the cystoscopy, or were they, or I can do
Um,
histology while you're looking if there was anything that you have?
Well, while she's pulling that up, give me a moment to.
Okay.
I've been around feline lower urinary tract disease since I was a resident. That's been a long, long time, and when FUS was the diagnosis, uh, and I won't bore you all with, but these. Some of these terms are only really properly used as a final diagnosis after a process of elimination of all other diagnosable possibilities. And what happens is that people skip over all the diagnostics and evaluations and go directly to the idiopathic sort of, we replaced FUS with FLUTD, okay? Changing the name without changing the process doesn't make it any better, okay? And now we have better understanding of certain things, and we are left with incomplete to no understanding of some other things. And in the end, you have to just be careful about these terms, but even interstitial cystitis is a presumptive diagnosis unless you've got a biopsy that shows interstitial inflammation. But most of the time, cats with dysuria and hematuria and nothing else wrong with them don't have much inflammation. So even the term is a little goofy. So, but enough from my soapbox feels a little shaky under me, so I'll shut up.
No, I think it's a good example of how terminology evolves, especially in a field that is now becoming its own specialty. It's going to continue to evolve. And a lot of the people who are doing the diagnosing are stuck in the terms that they used when they were in vet school, right? So unless you specialize in one, it can be very like not sure about. I mean, I still have pathologists send me consultations, and they're calling it transitional cell carcinoma, and they're pathologists. And so, I think that you get stuck in what you were trained in, and so then there are people who don't like specialist pathologists or pathology specializations like I have. And they kind of think we should be a jack of all trades, but really you can't keep up with it. So maybe that's my soapbox that I'm standing on is that, it does even somebody who is a urinary specialist, I do need a review of what term means what, and I don't want to use the words inappropriately. But ooh, sorry, that zoomed in real fast. You guys are hopefully seeing two small pieces of tissue. Correct? Okay, so this is another little commentary about cystoscopic specimens. I mean, I know this isn't cystoscopic. This is from when you were at the PCCL. But so this isn't like you didn't just grab this. You took an incision, correct, with an actual
Yeah,
blade.
I was
Okay.
very proud of how large these were. These are much bigger than what we normally send you.
They are much bigger than we normally see from the cystoscopic samples. I also read a lot of samples, obviously, through Zoetis reference labs, and a lot of those are just regular surgeries because they go in to remove the stone and then they take out like a full thickness bladder wall. And so I can see if it's a polyp, I can see like right where the polyp grows off of the mucosa. And so those samples are enormous. And so, it is a little bit about getting used to what you're going to be provided with. And I think, I'm not sure if we bisected this or if you gave us two samples. I can't remember. I can look at the report.
I think we gave
Um,
you two samples,
okay,
or
that
it's
makes
possible
sense.
maybe we gave you one and one went to culture.
Oh, okay, maybe that's true too. So we always, for the pathologists that are in here, when you're reading a biopsy sample from bladder, I like to inform the clinician what exactly was on the sample. So like, did we get urothelium? Did we get lamina propria? Did we get smooth muscle from the detrusor muscle? Um, I also sometimes I have a little problem orienting if the urothelium is ulcerated, especially in a case like this where there's a lot of blood hanging out here in this kind of loose connective tissue. So my question to myself is this lamina propria and is the urothelium up here ulcerated or is this expanded hemorrhagic serosa? And so it can be difficult. Some of it I think is probably has expanded hemorrhagic serosa because we've got some large blood vessels that would be more common along the lining, the exterior lining of the bladder. And so then I have to ask myself, well, where, if I think this is serosa that has expanded and we can look at this lining cells, they are not urothelial cells. There's a lot of like, nuclear debris and stretched out chromatin, or I guess DNA, nuclear components along the surface. So I'm not seeing urothelium on that edge. And then I try to find other places that have it, and it's very, very difficult to try to say that's a vessel right there, where the urothelium might be. And the and then also my experience, especially when you get small samples, and this even comes from like having done, autopsy pathology for a long time, is that um, if you were to cut the tissue, the smooth muscle cells, they have the ability, obviously, they're muscle, they have the ability to contract, right? And the overlying mucosa could actually kind of be uh, like a larger surface area, and the smooth muscle itself has kind of contracted down. Or alternatively, if the cut isn't really perpendicular through the sample, you might have a sample that like misses the urothelium but catches the smooth muscle. Because it's kind of gelatinous and the mucosa kind of gets pushed away during that whole part. So it can be, especially in these types of samples, difficult to find the urothelial region. So that's what my little problem is here, or was there. And then I think I found a little bit that was inside of the tissue. So man, it's gonna be hard for me to and even so, whatever I thought was going to be the lining portion of it was still, it was ulcerated. Like I didn't see the actual urothelial cells. 1 second. It was in a cleft. Okay, so as I'm kind of going through here, I'm noticing that we have hemorrhage, but it looks fairly acute. I don't see that many hemosiderin-laden macrophages, so I think that this also could be part of the surgery process. We've got a little bit of polymerized fibrin. We do have inflammatory cells that are kind of adjacent to the regions of fibrin. We have a little coagulum of fibrin in here, and I think this is where I was wondering if we were in the actual surface, the exterior surface of the bladder with a little bit of fibrin on the surface. Did you think the exterior surface of the bladder stuff looked weird, or did you think it would just felt thick?
It maybe it was a little bit more like vascular
Okay.
than for a normal bladder, but not
Okay.
horrendous.
The closest thing I could think that might have urothelium or might be urothelium is this area here. And so I was of the opinion that we had our lumen here, although I can't guarantee this isn't just serosa that's been enveloped by itself, but that these cells here are lining that space. Sometimes they are ulcerated and there's a little bit of neutrophils. This here would be more consistent with what we see in lamina propria, where it's loose connective tissue, often filled with fibrin, hemorrhage, and small amounts of inflammation. And then if we go further out, that's when we get to our smooth muscle. The area at the top here, I was more of the opinion that this was serosa because we had so many large arteries right next to the surface, whereas that other little cleft I showed you didn't have all those that number of large thick-walled arteries. And so there are inflammatory cells here which have a mix. So there's some neutrophils, there's some macrophages, a few lymphocytes and plasma cells. Again, not a lot of hemosiderin-laden macrophages, so I don't think a lot of this hemorrhage was pre-existing. And then it is doing the thing that the lamina propria likes to do, where it has, and they're cleaning our street right now, so it's very noisy. Where a lot of polymorphonuclear cells get kind of attracted to those superficial capillaries and kind of home there and rest there. We assume that they can migrate out and get into the interstitium. That's how you get inflammatory cells to the interstitium. But oftentimes when you're looking at urinary bladder samples, you're going to see more inflammation or inflammatory cells and leukocytes within the superficial capillaries than you will actually see in the stroma itself. So because of this, we did request a gram stain, which I think is the previous one. And the gram stain is, I think that's just that other part. Let me go back to the other. There. Oh, no. The gram stain will label, and I'll show you a different case that actually has really good gram stain labeling, but it should show gram positive, gram negative, and they should be in that little clefted area that we were interested in originally, because we're thinking that it's going to be a luminal infection. We had negative results based on this. There was no positive staining. And then Steph really liked this because she said it looked like mint chocolate chip ice cream. So she thought the gram stain was really pretty. But now I can show you a gram stain that actually does look like it is positive. But so my wraparound diagnosis was, I see a little bit of inflammation. I see a little bit of fibrin polymerization. I see some hemorrhage, which actually a lot of that hemorrhage could be from the procedure itself. And I am fairly convinced that there's erosion of the urothelium. I did think that arteries were increased in number, and I wasn't sure what the significance of that was. Obviously, we're taking a random sample through the wall. I didn't know if they were more tortuous. Sometimes like arteries will get, especially if they're there's a lot of remodeling, they might get kind of more curvy. If you think almost like, think about like when you look at somebody with varicose veins, it's not that, but it's that same kind of squiggly appearance. And so if you were to take a cut through that, you might see more cross sections of the artery walls and those big arteries. And so and that might have contributed to the fact that the bladder wall felt thicker than normal. But I didn't know what to diagnose the arteries with other than they had increased tortuosity, I think is the term I use. So it was a whole bunch of, I'm giving you a description, but I don't have a definitive diagnosis. And this is also not the most inflamed bladder I've ever seen. There's just scattered neutrophils. What did you guys decide to do with this case, Steph?
No, that's the question. So post-surgery, he's no longer having hematuria, but he is still absolutely having plaquuria and periuria. So I may send him to NCSU for radiation. They're looking at radiating cats with presumptive FIC. And
Do you think that the sludge stuff, like, it's not every urination that he has viscous urine? It's
she
just
still
when you,
describes his urine as being very sparkly, like there's mineral in it. I don't
and you
know if
can't send
maybe
that out
like,
for analysis to see what's in the urine then? Or is there
I don't
is there
know
a
if
place
it's,
that does that?
yeah, I mean, I would assume it's struvite, because for the most part, even like very tiny calcium stones are usually relatively easy to see. We have been, I'm trying to like get his urine into a place of being appropriately dilute and like acidic for struvite stones. But she's like very distressed because he's just still so uncomfortable.
Uh-huh.
I could believe that like there could have been a very tiny stone, and just like between placing the trocar and like flushing and then actually going into C, and because it was so bloody that maybe we flushed it out and didn't realize it. But he's just still so uncomfortable that I'm a bit desperate. I don't know. I don't know how well the radiation is going to work or not, but that may be end up like what we're reaching for to see if it brings him any relief.
For the other clinicians that are on, I know that sometimes we'll give you kind of descriptive diagnoses that doesn't give you a nailed down category of disease. What would you do with this type of case? Anyone?
What
Dr.
diet have you what diet is he on?
He is currently eating a non-prescription urinary wet diet. I think he's a bit tough to get to eat other things sometimes. And I've asked her to come back in. Historically, his UA has not been great. From a USG perspective. Let's see. Down my last notes.
And if she's looking for that, there's not like, I mean, so I know we can send things off for stones, but we can't just do a chemical composition of urine to see what's in there.
I don't know if it would be that helpful without an actual stone. Like even if he has like struvite crystalluria, yeah. So on his last UA that I have, his USG was greater than 1050, and he had 1 to 5 struvite crystals per high power field.
Yeah, so he's been a bit of a challenge then to get his USG down, isn't he?
Yeah.
And is she doing things to try and increase water intake in other ways?
Yes.
Could you try like Purina Hydrocare?
I think we've tried Hydrocare. She says she's got like 5 different forms of water. She's got like 5 different fountains, water bowls, etc. They did just get another cat, which I'm not sure will like help the situation. She does have like N+2 litter boxes. She's got like the feel away. We've got all the like kind of normal memo type. Gosh, I don't even remember what memos, like something environmental modification for the pathologists.
I had to look that one up too.
Is he an indoor only cat?
Multimodal, that's it.
Is he indoor only?
Is he what?
Indoor only.
He is indoor only. He's definitely fat. He could lose some weight.
And I appreciate this is a bit of a difference between the US and the UK, because I think you have a lot more indoor cats in the US, but I fixed some of these cats by telling the owners they have to start going outside. So that may not be an option.
Can they go outside and like leash walk, or does it have to be like outdoor access to just do what an outdoor cat wants to do? All right.
Yeah, I think so, because I think it's like stress, and like for some of them, just using a tray is never going to be their jam, right?
Yeah.
But what pain relief have you got him on?
Right now he's on, like, prescription wise, he's on GABA and fluoxetine, and I'm just about to get him started on amantadine. But I'm open to other suggestions. I think the owner is also a little, like, from an FIC perspective, he's like, he is the most easygoing chill cat. And which is true, like in hospital, he's a very easygoing chill cat, but he's very easy to medicate is the upside of that. So
Okay.
if you have other meds you've reached for that you think have been very helpful, she would absolutely put him on them.
I mean, I haven't used it much, but Julie talked about amitriptyline in her lecture that she gave, didn't she? And have occasionally reached for that, so that might be another option. But
And I would say from a pathology's perspective, so there's plenty of times where you will get a biopsy, and I think I even had one recently from Tufts. That like they kind of the same situation. They thought they were going to see a stone. They went in, they didn't see any stones, and they, just went ahead and grabbed some tissue and sent it in, and it had similar like mild perivascular, superficial neutrophilic inflammation, a little bit of hemorrhage. There were some, it was chronic because I could see some hemosiderophages in there too, so it had bled previously. But like I saw like 3 spots where I found a crystal embedded in the wall and neutrophils around it. I mean, it was, tiny little microscopic crystal, but I think that obviously they can do microabrasions, makes sense, but I think sometimes if they get stuck in there, even if they're just crystals, they're gonna set off some inflammation, and it's gonna be this smoldering process. And if it happens anywhere in the bladder and it's very, disparate, widespread, and you take the tiniest little piece, not that I'm saying you should take bigger pieces, but like I can't, even though I've had examples where like I'm like, yep, there's definitely something's getting into the wall, and it's making the wall really mad. But I can't see that on obviously everything. So, I mean, maybe the speckle you saw was truly in the wall. It's just the sample we got didn't have it. So, interesting. Dr. Syme, I see you popped your face on.
Well, I'm just going to play devil's advocate and say
Did you say gerbil's advocate? You said devil's advocate.
devil's advocate. Sorry, but I was maybe I mean, how do you know that it wasn't that the bladder wall was inflamed and then a crystal got attached as a secondary thing? Because I'm just countering what you're saying with,
Yeah, I
the
agree.
observation that 50%, like in the original studies, 50% of cats had struvite crystals, regardless of whether they were cats with idiopathic lower urinary tract disease or whatever your favorite name for the syndrome is, or if they were um, symptom
Yeah.
free.
Yeah, I
And
agree. And I
also
don't think
picking up on
yeah,
Bex's
it
point, I
is.
think it's interesting that the face you pulled about letting the cats out, because I know that culturally, like when I moved to America, I was horrified, like seeing these cats like trapped inside looking out of the window, and I was like, how can anybody do that to a cat? It's so mean. And then after 4 years I came home and it was like, how can anybody let their cats out to play in the traffic? It's so mean. But it is interesting how different your expectations can, or your, yeah,
Yeah.
like how a culturally, well, not to mention ripping nails out and things like that, but there are just huge differences culturally between the
That
two
is a
countries.
very prescient statement. I think I hope that with the expansion and with us being more specific about urinary pathology and urinary bladder and urethral pathology. I mean, it's easy to say if it gets stuck in your ureter, it's going to cause problems. But I hope that with like better qualifications and training and like more experience in looking at urinary bladder, that will better be able to kind of categorize some of the lesions, because I think it is easy to look at a bladder and say it has cystitis. It's pretty easy to call urothelial carcinoma when it's definitively smacking your face of urothelial carcinoma. But it's these weird kind of cases that are in the middle that are like, I mean, I gotta give them something. I know I see neutrophils and they shouldn't be in the tissue. So that would be really helpful to do. Also, if we were able to do like prospectively get cats that would be at the time of euthanasia and get samples throughout their biopsy, like throughout their bladder, to see like widespread lesions, would be helpful, because again, we're looking at the tiniest little piece of a fairly large organ. And with the kidney, we can usually say they probably relate to one another, except for in weird instances. But I'm not sure if we can always apply that to a urinary bladder. So I am going to switch over so we can show a positive gram stain, so you guys can see some of the lesions that might happen. This is Dr. Gordon's case. I know he was on for a moment, but I think he had to leave. But I will at least be able to show you the information for this case. One second. This is a Doberman, and let's see, Bruno is all I know, so maybe it's any name. We really didn't get a lot of history on the form other than the dog was about 2 years and 10 months old and was underwent evaluation for and so we kind of got a weird sample. Again, this is going to be a good example of how the samples that we get kind of get shaped and like curled upon each other when they're getting transferred to our lab. I think I went this one. Bear with me for a moment. And let's see. Oops, no, hold on. I think 1 second, I need to go back. Stop sharing.
Would
that
you
one.
find it helpful if the bladder biopsies were placed on like foam, the way that some of the GI biopsies are supposed to be?
I think it would be if you could put any kind of like the lower layers, so like the detrusor side or the lamina propria. Oftentimes people will do it also for like put them on like tongue, like very small pieces of tongue depressor or something like that. Like that would be probably helpful from my perspective. It's not something that we've had written in the protocol, but I think it would be yeah, this is a simple one. I think it would be helpful if you can do it at the patient side. Just kind of lay it on some foam. We try not to put kidneys on foam because the foam will actually like kind of crush the sample, and especially in a disease where we really need good, well perfused capillaries in order to make a diagnosis from glomerular disease. We tend not to do. We don't want kidneys on foam, but I think the urinary bladder would be very helpful. Maybe we could just try it and see if it makes a difference, and then we could make better guidelines in the future. Okay, so now I'm hopefully sharing I'm sharing the gram stain. I'll show you the histology first. So again, we got a sample, and again, this is another case where I'm like, I see detrusor muscle, I see what I think is lamina propria, and I see this in the middle, which I think is probably going to be urothelium, but as I go along the structure, I can't actually see where the urothelial cells are. So if you can compare that to what I was talking about with Steph's case about going along the surface and trying to find the cell type that tells you this is the inside of the bladder, and another cell type tells you this is the outside of the bladder, it can be kind of difficult. So this one is completely absent as well. We've already gotten our little area here that we're concerned about on histology. But as I kind of went around the circle, and I also described it as it's a pocket in the tissue, because if you zoom out, the smooth muscle and the lamina propria collagen is encircling it. So if you envision about how this was taken, and I don't know because I wasn't in the surgery, but I picture that, you know, an edge of the bladder was pulled apart and then a slice through the middle so that you got a center that has the urothelial portion and a lumen, and then you have the tissue surrounding it. It always it's very difficult a lot of times for me to orient myself when I'm looking at these things about how, I'm taking a 3D thing that you guys saw in surgery and trying to make it resolved on a 2D piece of tissue. We do have a few regions of smooth muscle. A lot of this is actually collagen from the lamina propria. So, and it's pretty dense collagen. So it makes me think that whatever's been happening, it's been happening for a long time. I was of the mindset, and I will be very clear. I'll be like, I don't really see ulcerated urothelium, or also I don't really see urothelium, so I assume it's ulcerated. This makes sense that this would be the lumen. We have our areas that we're concerned about here. We have lamina propria, and then we're starting to get some bundles of smooth muscle. And remember, it's a very like multiple planes all intersecting with each other when you're looking at smooth muscle, the detrusor muscle of the urinary bladder. The other thing I've noticed from cystoscopic, or I guess maybe not cystoscopic, that's not the right thing to say, but from samples that come from urologists and endourologists and nephrology people, is that you guys are much better, or not much better, but much more commonly using like the laser, the CO2, whatever, all of those things to for sectioning. Whereas, the vet down the street that takes a stone out of the cat is still using scalpels. So a lot of this is kind of artifact from the ways you guys are incising the bladder. And so I have to usually ignore this. This is just what we would see if we were removing a skin sample and you guys were using like a CO2 or whatever those things are called that you guys use to remove samples. Is that a laser? Do you guys use lasers? Now I feel like I'm just talking to, I obviously am not a surgeon. So it does cause artifact in the tissue. It basically fries the tissue in the deeper regions. So we have these areas here. I was very convinced that we had probably bacteria. We have another area here. I'm not sure how it's doing this deep in the soft tissue. And let's see, the first one. So I did tell him, I see basophilic material. It's probably bacteria. There's also a possibility that some of it could be mineral. So I'm going to do 2 stains. And we, as a policy, already have it set up so that we just request it. We don't have to wait around for you guys to request it and ask for you guys for your opinion. When it comes to urinary bladder, we just say we're going to request what we need to a limit. But we were able to request these two stains. So this is the gram stain, and this is what a positive gram stain should look like. So all of this is all these are little basophilic cocci. They're dark blue. They're gram positive. He did text me and say that the dog, excuse me, has a persistent and multi-drug resistant infection, and he is having trouble controlling it even to this day. This dog's still doing at least being managed. And so this is quite a big colony of bacteria. Usually we'll just see small colonies like this. And it also is present deeper in the tissue too. So again, I'm not sure, is this another region of the urinary bladder that was kind of splayed, that had been previously splayed open and now it's kind of sealed on itself? I don't know. I do not know what this little fibril is. Most likely it's probably a little bit of gauze that was associated with the surgery. Being a fiber there. I don't think it's an actual pathogen or anything like that. But so that's what a good positive gram stain would look like. And then our von Casa is to look for mineral. And so I wouldn't be surprised, and I was not surprised to see a little bit of staining of the tissue. So we do think that there probably is a tiny bit of mineralization of this tissue as the cells are dying. And so but the amount of bacteria is mostly what that big group of basophilic cocci structures, circular structures were. And I'm not entirely sure of the whole history about how this dog ended up getting this infection. But I did want to show you that sometimes the gram stains are very informative, and sometimes the von Casa stains can be very helpful too. To when they're positive. I mean, they're very helpful when they're negative, because they tell you we didn't really see anything. We went back, I think, I'm not sure if Steph mentioned it, but they did do tissue culture of Cheese, that original cat, and nothing grew from aerobic culture. And so that would fit with the fact that I saw nothing on the gram stain. Um, and that was tissue culture. It wasn't just urine too, so that's also very helpful. It is, nice to see that sometimes we actually do get a positive stain that can help the clinician as well. Obviously as Dr. Gordon had biopsied this particular case, he did take tissue for culture, and that's how they know that they have a multi-drug resistant bacteria in here. Okay, so we have a question about von Costa as a baseline cystitis stain routinely on the chat. I don't do a von Costa. I don't do a gram stain in general. So I'll see the histology, and if I have a lot of neutrophils, I'll do a gram stain. If I have foci that would be necrosis, I'll add the von Casa. And the other thing is that when it's that like basophilic and kind of almost making like larger regions, it's helpful for me to look and compare the von Casa to the gram stain, because when the gram stain came back and nothing was showing, it's just easier to do it all at once, in my opinion. But the I guess that's probably part of the reason I do everything together. But the von Casa is really, honestly, it's just showing us mineral, whereas we don't actually have an alizarin red, which is going to show us calcium, actual calcium stuff. But we don't have that in our lab, so I think it just helps me in the fact that I know I can add it on. Does that answer your question? That was kind of a ramble. Okay. And as we're getting closer, so like we have 15 minutes, I'm very happy to show you guys a couple of other cool special stains that we don't traditionally do in kidneys, but it won't really be about the case. Is that okay? I'm the only one whose face I can see, so yes. Okay, Steph gives, well, one of them is also your case. So we will show a couple pictures of Bernie, and then I'll show a picture of a Tufts case that recently came through that has some pretty impressive material in it. Okay, so to do that, I need to look at Bernie first. So Bernie is going to be a dog that has kidney disease. He's being managed by Dr. Skinner. It's bad kidney disease. It's a membranoproliferative pattern. And we already have the histology back and the immunofluorescence to know that there's immune complexes there. It's pretty aggressive, in my opinion, as far as the lesions on the histology. So I will pull that up and then I will show it to you. Let's see if we can do this. Is that showing the right one? Hold on.
Bernie's been a great case to work through all of the possible causes for severe AKI. He started out with concern for heat stroke and then lepto, and then despite us really thinking he had lepto, he definitely didn't, and we eventually biopsied him.
Okay. I didn't realize that was part of the original differential. So, and usually I don't see everything until I'm writing up the history at the end of the thing. But so obviously this is one of our routine histology stains. So this is a PAS, but it's my stain I like to start with. But I do want to give you the impression that there is a lot of hypercellularity in these glomeruli, and the capillary walls are going to be thickened. They're going to be even double contours can be even seen with just the PAS. We didn't even need the Jones for that. So we have a membranoproliferative pattern. He has a couple of other complications. He's got quite a bit of scarring as well. So the trichrome is going to show us a lot of the fibrosis. But what I noticed on the trichrome, and I'll go back to the PAS, is some of these vessels here, and this is probably like an intralobular, maybe even really close to where the arcuates are at. So like a fairly substantial artery, but you can start to see the smudgy blue stuff that's in the wall. And so that's going to be hyalinosis. And when we go back to the PAS, we're going to see that same thing as pink of plasma that we would normally see we can see hyalinosis in glomeruli, but it's going to be hanging out in the arterial wall. So I was like, uh-oh, the vessels are messed up. The vessels are not great. Is he hypertensive, Steph? You said kind of?
Yeah, he is. He's on amlodipine.
Okay. So then I was like, okay, let's add an extra stain so we can look at the vessels. And then I also was concerned based on, I think his H&E is coming up next. No, it's the trichrome. Hold on one second. That's the Von Casa. Oh, well, hold on. This is the H&E. So looking at the H&E, I was a little concerned that there was some kind of like, hopefully you guys can see this faint purplish stuff around basement membranes. And so I was like, uh-oh, is he mineralizing his kidney? I think he might be. So I asked for a couple of extra stains. So I asked for the elastin stain, which is this one, and this is to look at the arteries. Now, I will be clear that, remember, as we're cutting through, we're cutting each section on the block, that we might not always get the best, like, oozy hyalinosis region that we had in our previous images. And we didn't really get, like, this was our area that was hyalinotic in the trichrome and the PAS. But we just were now in a deeper section of the vessel. But there is a vessel up here. Oh yeah, okay. So this is and this is all this is mild. I see much worse when I look at humans, but I do think it's a good teaching case for the pathology people on here is that here we have an artery and you have elastin and it should be lining the luminal side of the artery. So it should be kind of that faint gray. And then anything to the luminal side should just be endothelium. You should only have endothelial cells. But when you start to see this disruption of the internal elastic lamina, and then you start to see extra tissue in here, some of these are endothelial cells, some of them are fibroblasts, some of them are myofibroblasts. This is technically arteriosclerosis. So not only do we have hyaline and plasma being pushed into places it shouldn't be, which is hyalinosis, we now have remodeling and thickening of the arterial wall. So we have arteriosclerosis. To be clear, when I see this in humans and we do this in humans, it's like obliteration of the artery. So this is still mild, but we don't get to see it that often as veterinary pathologists. So I wanted to use it to show everybody that you can make a diagnosis by looking at, hey, here I've got really good internal elastic lamina and it drops out, kind of like, fibrillates. And then I have new tissue being pushed onto that side, on the luminal side. So that was the elastin stain. And obviously I could do more and more sections to try to get better assessment of, how much elastin or how much remodeling we're having. And the next stain I also did was for the minerals. So I was seeing those tubular basement membranes that were mineralized. So this is Von Casa, exactly like I did on the bladder for Dr. Gordon's case. We did it here, and I'm not saying we did it. It's Texas A&M has a great histolab. Like Jessica Hokamp and Mary Nabity, make sure you go tell them that I gave them many appreciative comments during rounds today. But they have a great lab and they're really good at working with you. If you see something that's not great or not, if it's off, they'll be very excited or very helpful in trying to figure out what the problem was and restaining it for you. So Von Casa shows mineral as being brown. And, in that last bladder case, we just had specklings, right? And now we have it all along tubular basement membranes. And so he's very much mineralizing his kidney. The other thing is it's mineralizing Bowman's capsule basement membrane. So not only are tubular basement membranes being mineralized, but Bowman's capsule basement membranes are being mineralized, which is something I see when it's really bad disease. Now it's patchy. There's certain areas that have mineralization, and then you go to other areas that are less mineralized. So it's not diffuse. Oftentimes I can see it all throughout the core. But this one's patchy, but it's definitely there. So I told Dr. Skinner and Dr. Foster to make sure he stops mineralizing his kidneys. I think he's being dialyzed, so he is still mineralizing his kidneys. And we might discuss him maybe next month because by then we'll have the electron microscopy back. So there's that. And I have one more case that I can show a really cool special stain for, if I can remember what number it is. Let's see. It is Chocolatina. Okay. It is funny, like being able to just say the names of these patients because when we're in human kidney rounds, we have to do everything with abbreviations. This is an autopsy specimen, so it's going to be a much larger specimen. And it is, I think, a 3 or 4 year old Frenchie. Did have a history of Lyme exposure, but had been in the past. It's from Tufts, so we already get worried that there's going to be something wrong with infectious disease when we're talking about Tufts cases. And so the histology was such that I think that owners wanted to do everything in case it was a congenital lesion and maybe even hereditary. Because the dog was fairly young. So they had sent us the whole shebang of all the samples. But when we said, hey, on histology, it looks like it's going to be, again, a membranoproliferative pattern. Then they said, that's fine. They're like, as long as you can probably, it's membranoproliferative, then we'll be able to stop there and that we don't need to pursue anything because we know it's not like a congenital or a maldevelopment problem. So again, to show you that it's membranoproliferative, a lot of hypercellularity in the glomeruli. You start to see, even on the PAS, this kind of brown material in a lot of the tubules. That is fairly well established in the H&E. And I think this dog, from the history, ended up actually being euthanized because they knew it had really bad kidney disease, but azotemic proteinuria, but also developed a GI bleed. And so I think that was pretty significant. And so that's when they decided to euthanize the dog. But we have all this pigment inside these really degenerating and injured epithelial cells. And so I wanted to better characterize what this pigment is. Is it just bilirubin? Because dogs store bilirubin in their kidney. Is it other kinds of iron pigments? Is it ceroid? Is it lipofuscin? And so we did an iron stain for it. And I will flip back to that one. I don't always do an iron stain, but this one was pretty impressive. So, an iron stain is a Prussian blue, so it's going to stain things blue. And you can see all of the blue material hanging out in those very injured and damaged tubular epithelial cells. So there's definitely iron turnover within the epithelial cells. I am not entirely sure how much of it would be associated with the fact that there's a lot of bleeding through the GI tract, but not only did we have bleeding through the GI tract, if you look at the other regions of the kidney, I was kind of hiding them from you. Let me get the trichrome. There's also bleeding in from the glomeruli. So this was a glomerulus at one point. That is a glomerulus that has a lot of hemorrhage into it. So there's probably a lot of endothelial damage in these glomeruli, and so blood is getting into Bowman space, and then being filtered down into the tubules, and so that then would be digested as it's going through the lower portion of the nephron, and a lot of the iron pigments are being uptaken into the tubular epithelial cells. And even in the deeper regions, we were starting to see red cell casts. So these very, very dark polymerized material with red cells. They probably have tam horseful protein all intermixed with them. So this guy wasn't only bleeding through his GI tract, but he was also having a superimposed endothelial injury in his glomeruli. There's definitely an immune complex thing going on here with most of the glomeruli, but some of them are completely killing off their endothelial cells as well. So he's bleeding into the tubular portions of his nephron as well. So just kind of another gee whiz of an interesting stain that we can do, and we don't always do in the kidney, but it can be really positive and at least show that a lot of the tubular epithelial damage is probably because there's a whole bunch of red cells that are being filtered through there and being digested as they're going through the nephron. Okay, I think I got to the end of the special stain tour. Does anybody have any questions? I wasn't watching the chat, so. Von Costa. Okay, any other questions about anything? Oh, did you get, Chocolatina came to you? I guess you're, okay. Was there anything interesting? I'm not sure if you're able to speak. You might only be able to type, but was it like the rest of the body?
Interesting. Not really. I
Okay.
mean, that they already said, other than quite a bit of melena all over the place. Yeah.
Okay. I wonder did you think that she bled because of uremia or not
Yeah,
sure?
I mean, there wasn't a tumor. There's
Okay.
nothing really obvious when it comes to, like, it's one of those another annoying glomerulonephritis cases with no answers at the bottom.
Well, at least I'll give you an answer that they didn't have to do all the extra electron microscopy and stuff like that. Like I have sent you guys an email just to see if the clinicians want to stop here, and not have to do all the rest of the stuff and save the owner some money. So hopefully we'll get that information, and if so, then we can just finalize that on histology.
Yeah.
So Okay, any other questions? I know that was kind of a different way that we normally discuss a case intensely, and so this one was kind of more of a tour. We will have the next session in September. I think I am free. I don't see any impediments. It looks like it would be the 16th. So I will send out a request for cases early in September. And hopefully we'll have more cases to discuss. And if you guys have any questions, please feel free to send me emails. And please remind me of something if you want more people to be added to the list. I'm very happy. It's really easy for me to do. Okay. Thanks, guys.